Record. Hello. So we did a presentation on the sociology of innovative health technologies. So the first remarks the article makes is that there are three sociological approaches to understanding technology in medicine. The first one discusses technological determinism. So there are consequences as a result of technology, such as technological iagenesis, and that's illness or injury that's a result of medical care. There's a lot of contradiction in the technological procedures, such as medication for the relief of pain, contraceptives that allow women to control fertility, and so on. The article also pointed out that technological determinism is fueled by a suspicious blend of case selection and conspiracy theories. The second sociological approach is a social essentialist, which focuses on how the technology is deployed and used and how meanings are invested in them. They see that technology is a passive, non-communicable device requiring social interpretations to be rendered meaningful. For example, medical professions may use high-tech equipment to enhance their status or expertise or improve the quality of care for their patient. Patients deploy technologies to alleviate pain, treat symptoms, and prolong life. The third sociological approach is the art network theory, and it is an approach within studies that examines technologies and humans as if they had an equivalence. Ontologically wise, it questions what things are. Technology is an effective tool only when used by humans. In regards to epistemology, machines, human things, objects, and text can construct realities. So they then turn to discuss how technology is used for visualizing bodies and discuss the case of Mildred Blackster. So Mildred Blackster did not experience technology as alienating or dehumanizing as a technological determinist would approach it. She actually found it super interesting that she was able to see a CT scan of her body. However, she did not like the way that clinicians in different specialties interpreted the images that were taken. She was receiving the incorrect diagnosis of her pain and instead was given morphine for her pain. The patient knew that it was more than that, and on her fourth visit to a different doctor, they found the correct diagnosis for her pain. She just kind of wasted so much time and energy going to different places and waiting for someone to help her. This shows that technology is good, but malpractice within physicians need to improve for a better patient experience and a better trust between patient and doctors. Mildred Blackster did not like how her body was dissected in a way that her organs and tissues had to be looked at separately and differently scrutinized by different specialists, departments, outpatient clinics, and places within a hospital and even different hospitals. It is difficult for a practitioner to know whether an observed abnormality is problematically abnormal or normally abnormal. For example, I have an abnormally low heart rate, but that's because I've been an athlete my whole life. However, a practitioner needs to be able to know that my low heart rate is only due to being an athlete and no other external factors. There were many tests done and a lot of technology used, same in the case as Mildred Blackster. But she pointed out that being transported to multiple departments and being seen by multiple doctors gives a feeling of like being dissected and alienating. And I low-key agree with her because it's kind of true, come to think of it. Technology is great, but it definitely has its downsides. So another part of the reading discusses of biological waste and biological value. So what is waste and what is value? As a result of technological innovations and new codes of biomedical engineering, our bodies are becoming more Cartesian because we treat the body as an assemblage of replaceable parts, a veritable machine, exactly what Descartes said it would be. But then other argues that there has always been hybrids among us. Take a metallic body part, for example. Metallic body parts become human when it comes to the disposal of bodies. It is too human to be sold, but not human enough to follow the remains of the deceased into the urn and ruin the principle of total decomposition. Titanium doesn't burn and melt, and some crematoriums are hesitant to sell the metal in fear of violating social and ethical boundaries. So now I ask you guys, what do you believe we should do with the artificial body parts when we die? Let me pause here. Okay, next slide. Cool, great conversation. I believe that technology is our friend. There are pros and cons to technology, but it is arguable that everything that exists too. Technology has allowed for innovation, and not only in the medical field. We have been relying on technology ever since we discovered using things as tool, and we use it basically every day. Like, imagine a world without it, you can't. Obviously, there would be controversy to technology, and some people would want to take away or limit its powers, but we need it. Thank you.
All right. The article stressed a lot about the sociology of genetics, and the sociology of genetics is reflective of researchers who employ a sociological lens to study genetic theories, research, and practices, or the position of genetics in society in order to answer questions of fundamental concern to sociologists. Conrad's thesis on new genetics are consolidating reductionist and medicalized interpretations of health and illness inclined to the view that biomedicine is regaining ideological prominence. Genes, genetics, and human genomes have unfiltered popular discourses of health and illness in the recent decades and has gained attention from sociologists. Among sociologists, however, there are two contrastive positions. On one hand, there are noted those who point to resurgences in biomedical model of the biomedical model with a concomitant privilege of biomedical explanation for the cause of the diseases. On the opposite spectrum, there are those people who argue that the inheritance to genetic notions of disease are generating new forms of sociality. The term new genetics can be best described with the quote, "New genetics refers specifically to the body of knowledge and techniques arising since the invention of recombinant DNA technology in 1973. It involves research to the genetic components of human disease and behavior, which may have clinical applications with the provisions of genetic testing or screening of disease or risk factors of disease, and through treatment such as therapy or new pharmaceuticals. Geneticists have long recognized monogenetic conditions that here variation in an individual gene lead to onset of specific diseases, and children who inherit dominant genes from parent or recessive genes from both parents will develop the condition. Developments in the recombinant DNA technologies have given rise to more complex predispositional models of association between genes and disease pathologies. It is critical to understand the difference between these two terms, biological citizenship and genetic responsibility. Biological citizenship is also referred to as medical citizenship, health citizenship, therapeutic citizenship, and it describes the form of belonging, right claims, and demand for access to resources and care that are made of on a biological basis, such as injury, shared genetic status, or genetic or disease state. Genetic responsibility addressing how and by whom decision-making with respect to the morality of genetic information is approached. Genetic responsibility has become a key concept in both ethical and socio-empirical literature. Testing for genetic conditions alter the temporality of diagnosis and disease. Being diagnosed with genetic predisposition or genetic risk of a condition has the potential to transform an otherwise healthy person into a patient without symptoms, which causes the body to have greater likelihood of developing a condition. Research into people's response to genetic testing does indicate that holistically, men and women are able to rationalize positive test results and recognize that they are not definitive. Researcher Ian Whitmarsh found that men and women they interviewed recognized the indeterminate nature of their genetic-based diagnosis, thus appreciating that their genetic status is embedded within a broader context of their everyday lives. They did not see their disease trajectory as an inevitable or irreversible one, but simply as an aspect of life's multiple trajectories. The indeterminacy associated with predispositional genetics serves to amplify the uncertain inherited in genetics and health. What does it mean to be genetically at risk? You can take a moment to pause the video to think and discuss about what it means. Okay, now that we're back, a genetic predisposition, sometimes called genetic Oh my God, I can't speak. Suspectability is an increased likelihood of developing a particular disease based on a person's genetic makeup. A genetic predisposition results from specific genetic variations. They're often inherited from a parent. In the article, it mentions how the concept of being genetically at risk has become an influential factor in medical sociology. Having a genetic predisposition to a disease is where individuals are diagnosed as having increased biological propensity of contracting a condition. This genetic information may or may not be accepted as significant or used to alter ways of living in order to counter the increased chance of contracting ailments such as cancer, heart disease, diabetes, etc. There is, however, a thesis proposed that groups who share the at-risk status may develop a risky genetic self, as proposed by Novus and Rose, as a result of being genetically at risk. These biological markers thus form the basis of identity that propel individuals to take action. Novus and Rose argue in the article that individuals and their families have taken onto themselves the responsibility for the government of their risky genes in relation to a secular norm of individual health, but an obligation to their loved ones and to the future. Individuals thus feel pressured or an ethical obligation to seek out more information, procedures when it becomes better informed, so they might pursue appropriate strategies. When I think of this example, this scenario, I immediately think of those ancestry, like DNA tests that tell you exactly where you're from. I know a vast majority of those tests have features where you can pay to access information on health and how apparently your genetic makeup can tell a person's medical and health predispositions. This type of testing cannot tell definitively whether you or will not get a particular disease. Unexpected information that you receive about your health, family relationships, or ancestry may be stressful or upsetting in the long run. In a little over 30 years, bioethics has managed to position itself as a key node through which a variety of social, political, and scientific activities are refracted. In the US, bioethics has not only participated in reshaping the relationship between doctors and patients through the development of informed consent, it has carved a niche in the wider governance of biomedical research. Although the growth of bioethics is particularly noticeable in the US, it has made progress elsewhere. Sociologist researcher Dan Callahan has defined the task of bioethics as the determination, so far as the possibility of what that is possible, of what is right and wrong, good and bad about scientific developments and technology deployments of biomedicine. What are duties and responsibilities in the face of those developments? Broadly speaking, bioethics has been concerned with the deployment of the tools of moral philosophy and applied ethics to critically determine the moral worth of practices associated with biomedicine. For bioethicists, this development is best understood as a response to the novel moral dilemmas introduced by the growth of new medical technologies and research programs, and the necessity of reining in the paternalism of the medical profession in the 1960s and 70s. However, as researchers have argued, bioethics has not become an established source of critical oversight. Instead, it has become an opportunity for ethics experts to cope with dilemmas generated by technologies, which came to be seen, ironically, as value neutral in their creation, even while they're problem causing in their effects. And those are our references. Thank you. And if you have any questions, ask away.